So we're going to continue our deep dive into endometriosis, and we're going to talk about the other symptom of endometriosis, that is infertility. So obviously, close to my heart, being a fertility specialist and a reproductive surgeon, endometriosis affects fertility on almost every single level. From a very functional level to the fact that if somebody is constantly in pain, they're really unlikely to want to have intercourse, to the fact that endometriosis can cause chronic scarring in the pelvis, therefore change the anatomy of the structures. The structure that most likely gets damaged in this context affects fertility are the fallopian tubes. If endometriosis occurs and grows on the fallopian tube, then they can scar, they can block, and the fallopian tube is essentially then rendered useless. Therefore, people have infertility. However, sort of the most likely or the most important cause of infertility in the context of endometriosis is probably egg quality. In a state of chronic inflammation, follicles or eggs that are in their shells as they try to mature and develop, they just don't mature or develop very well. So this leads to poor quality oocytes as they try and grow up in this inflamed environment. Poor quality oocytes then really lead to poor quality embryos. From an implantation perspective, we think that endometriosis can downregulate or suppress the expression of molecules that help the embryo dock. Certainly, endometriosis patients have linings that are fairly resistant to progesterone, so you need much more progesterone than would necessary for the embryo to implant. At the level of miscarriage, we think that people with endometriosis is associated with repeated miscarriages and pregnancy losses. So at every level, endometriosis affects fertility. I suppose the question has always been, how do we deal with this? The difficulty with endometriosis has always been that a strategy to avoid this is to take the egg, the sperm and the embryo out of this chronically inflamed environment for the first couple of days of its development, the first 5 to 6 days of the development. That is using IVF to take the eggs and the sperm away, make them into embryos, and for the first crucial couple of days of an embryo's development, take them away from that chronically inflamed toxic environment before implanting the embryo in the uterus. The other solution is actually to do surgery to excise the disease as much as possible and to hope for a better outcome. There is certainly evidence that excising minimal to mild endometriosis improves fertility, but compared to IVF, the evidence is a little bit dubious. There are some people who will need IVF and IVF alone in order to achieve their fertility outcomes in the context of endometriosis. For other patients, you could do rounds and rounds of IVF for them, and ultimately they will still need endometriosis to be surgically excised. And the challenge is always to work out which patients you can avoid surgery on, which patients must have surgery. The approach that I take is really to have a chat to the people in front of me, say, well, what are our aims, what are our goals? If the goal is that to mainly fall pregnant, I'm not in that much pain, and fertility really is the main outcome, then you may want to try 2 to 3 rounds of IVF. If that's not successful, consider surgery. But if the goal is that actually fertility for the moment is secondary, I'm in so much pain, and I really want to avoid IVF as possible, then surgery is probably the better route.